Hi there, everyone. Welcome to this week's DDU teaching. I didn't introduce myself last week, but I'm Emma. I'm the Echo Fellow here at Nepean. So nice to meet you all. This week we've got the great pleasure of having Dr. Ramsy D'Souza, who is an intensivist at the Prince Charles and Caboolture Hospital. I hope I've said that right, sorry, in Queensland. So it's our pleasure to introduce him, and we will speak about restrictive cardiomyopathies today. Thank you so much.
Excellent. Thanks, Emma. Thanks for this opportunity to speak to you guys. Today we're going to speak about restrictive cardiomyopathies, and I guess it is an imperative to talk about diastolic assessment of diastolic dysfunctions when we're talking about restrictive cardiomyopathies. So we'll start off with a case. We have a 65-year-old gentleman who presented with increasing shortness of breath over the last 2 weeks, 2 years rather, and has been progressively getting more short of breath over the last few weeks. He needs 3 pillows to sleep. His excess tolerance has reduced from 40 meters to being unable to mobilize currently. And his current admission was to ICU for hypoxic respiratory failure, being in pulmonary edema, and was put on an IV on the following settings: EPAP of 10 and IPAP of 18 with an FiO2 of 0.5.
Sorry, Ramsay, your slide hasn't moved on.
Oh, sorry. Which one are you seeing, Louis? Has that changed anything?
No, we're still on the first page, Ramsay.
Okay, hang on. I might be sharing the wrong screen. Give me a minute. All right, so I'll just go back again. 65-year-old gentleman who presented with increasing shortness of breath over the last 2 years, and over the last few weeks has been having orthopnea, requiring 3 pillows to sleep at night. His exercise tolerance has reduced from 40 meters to being barely able to mobilize now. And he's now in ICU for hypoxic respiratory failure from pulmonary edema. He's on an IV with an EPAP of 10, IPAP of 18, and an FiO2 of 0.5. All right, so he gets an echo, and this is what we see. Emma, do you want to have a crack at just describing what you're seeing in the parasternal long axis view?
Sure. Oh, hi there, Sid. Yes, parasternal long axis view, markedly abnormal looking heart. I can see a normal sized cavity slash on the smaller side, and very thickened left ventricular walls with almost that sort of speckling appearance of those. The ejection fraction or the systolic function or thickening of those walls looks to be reduced. Then I think that's mirror artifact that we're seeing beneath, but I'd like to see that in more views. It could be a pleural effusion, the left side of pleural effusion. The left atrial size looks enlarged, and again the mitral and aortic valves look structurally normal slash perhaps slightly thickened, but they're the opening time of those looks quite reduced. I'd be concerned about this patient having a reduced cardiac output state. The right ventricle appears hypertrophied in that single view. Again, interrogation in other views is needed, but the right ventricular outflow tract wall seems to be thickening okay. And it doesn't look terribly enlarged in that view, the RV, but again, need to see it in more views. And then looking at the measurements that you have there, that's severe LV, increased LV wall thickness of both the intraventricular septum and the posterior wall with a slightly, normal cavity size.
Excellent.
And if
I think that was a very good description, having a very systematic approach and describing all those findings pretty good. Yep, so there's biventricular hypertrophy and normal cavity size in the left ventricle. So these are the remarkable findings that jump out to you as soon as you see this view. More importantly, it's also your left atrium, which is dilated, which is again giving you an indication that there might be raised filling pressures. All right, so now here we have all right, so again, just a zoomed in parasternal view. I guess what I wanted to show you there was the speckled appearance in the interventricular septum, which is quite obvious out there. In the zoomed in view, you can see all this sort of speckled bright myocardium, which would be more than a normal myocardium. Also here, I don't know if you can really appreciate, how's that coming across? How's the frame rate coming across to you? Okay, good. So, this is a very hypertrophied heart with a normal to small chamber size of the left ventricle. And you can appreciate both the atria are remarkably enlarged with a slither of pericardial effusion. Okay, so I think very important findings there. Left atrial volume index was 70 mils per square meter. Okay, so what would be the cutoff for an enlarged left atrium? Anyone wants to have a go?
The volume is going to be 34 millimeter.
That's right, Sid. So that's 34 mils per square meter. That would be the index,
yes.
which would be cut off for an enlarged left atrial size. And though I've not put the tricuspid regurgitation pictures here, the tricuspid regurgitation jet velocity, maximum velocity was 3 meters per second. So again, indicating that there is some degree of pulmonary hypertension. Then we put a pulse wave Doppler across the mitral valve. And what are we seeing? Sid, do you want to have a go at what you're seeing here?
Yes, this is the pulse wave Doppler across the mitral valve leaflet tips, showing the E wave velocity of 67 centimeter per second. But the E to A ratio is 3.5. The E to E prime, I need to calculate that, it's less than 5 anyways. The septal E prime is less than 5 centimeter per second. Yes, 2. Sorry, I didn't see that. 2 centimeter per second with the E to E prime is 39, reflective of raised LV filling pressures and possibly grade 3 diastolic dysfunction. But I need to, again, looking at the subjective, we have not measured the LV volume and the TR size, or we've not seen those images yet. But objectively or subjectively speaking, the LA appears larger with a concentric LVH, thickened LV myocardium, and raised filling pressure. It's probably pointing towards fitting kind of 2 criteria for the grade 3 diastolic dysfunction.
All right. So from what you've described, that's perfect, right? So you've described this as grade 3 diastolic dysfunction. So you've called this a restrictive pattern. So what are we thinking in terms of what we've seen echo images? What are we really thinking? What could be the likely differentials?
Well, it's a grade 3 diastolic dysfunction with the concentric, with the left ventricular hypertrophy. It could be, the differentials are most likely the restrictive cardiomyopathies, which includes amyloidosis. It could be, I mean, hypertensive heart disease, probably not the right one, but it does give you left ventricular hypertrophy. Yeah, eosinophilic, I'm just trying to think. I can't remember the exact, all the names.
That's good, Sid. So yes, it could be restrictive cardiomyopathies. However, just a very hypertrophied heart. So severe left ventricular hypertrophy could also look similar. Could have diastolic dysfunction, could have a restrictive physiology, and it could be hard to differentiate. The point I guess I'm trying to make is it could be really hard to differentiate whether it's just a restrictive cardiomyopathy or whether this is hypertrophic cardiomyopathy with a restrictive diastolic dysfunction. Okay.
Ramsy, can we see an L wave in that info?
That's very good,
pattern?
Emma. Yes, so that's a very good point. So you can see this L wave as well here. So the L wave is quite a specific marker of raised left atrial pressure, filling pressures, especially if its velocity is more than 20 centimeters per second. So yes, it's definitely more than 20 centimeters per second here. You could also see the L wave in severe bradycardia, but very often the L wave velocity will be less than 20 centimeters in those circumstances. There's one of the pet questions of DDO examiners is, assessing diastolic dysfunction. What they would like you to talk about is, the pitfalls of using the A wave, E wave, and the L wave, talking about, whether these are load-dependent, load-independent markers. So I think this is what is very important from the DDU point of view, talking about the pitfalls of assessment of diastolic dysfunction. Okay. Again, when we are looking at Doppler, talking about Doppler angles, having the gate correctly positioned, optimizing the images, and measuring, so making sure your Doppler line is aligned with your blood flow. So you don't have a very large Doppler angle. All right, quickly we'll brush through, diastology. What do the flows across the mitral valve look like, and also the pulmonary vein velocities. So this is how a normal pressure curve looks like in the left atrium and the left ventricle. Okay, so that's normal. You have a larger E velocity, a smaller A velocity. As the diastolic dysfunction gets worse, begins, the first stage is usually just there's impairment in relaxation. So the relaxation is very slow, which means the filling of the ventricle starts getting impaired, but the filling's happening over a prolonged period of time. So what you're seeing is you see prolongation in the interventricular relaxation time, the isovolumetric relaxation time. Then you see that when the mitral valve opens, you do get a flow, but because of the slow relaxation, the flow does not reach a maximum velocity. It doesn't reach a very high velocity. So that's what you see. The E velocity is slightly low, and the flow continues over a period of time. So your deceleration time, the deceleration time of the E velocity is longer. Then the atrial contraction happens, and the left ventricle is not completely full. So when the atrium contracts, you do get an increase in velocity happening across the mitral valve. So you get a smaller E velocity and you get a higher A velocity. So that's impaired relaxation. As you progress through diastolic dysfunction, coming to the restrictive phase, what happens is classically described as the ventricle is so stiff that even when the mitral valve opens, there is a big pool of blood. So you see this is the left atrial pressure here. It's already elevated. So there is a lot of blood sitting in the left atrium behind the mitral valve. The mitral valve opens and a gush of blood moves into the left ventricle. And so you see this high velocity happening at the E wave. However, because the ventricle is very restrictive and cannot accommodate a very large volume of blood, the blood flow rapidly declines. And so you see that deceleration or the deceleration time being very short, followed by, so the ventricle is already full now, it's very stiff, it's already full, the pressure is already high. And when the A wave kicks in or the atrial contraction happens, you do not really get much flow. So your A velocity is very low. So classically having that large E to A ratio, okay? And same thing happens again with the pulmonary vein velocities, is from predominantly systolic flows, you see that you start getting predominantly diastolic flows, and the atrial wave reversal that happens with the atrial contraction gets longer and longer. Coming specifically to the restrictive pathology, restrictive filling defects, this is how a normal filling pressure looks like. So you have the atrial pressure wave, that's the atrial kick, and your left ventricular pressure, that's in the early filling phase. You still have the pressure pretty low towards the end of early filling phase. And in diastasis, you see a gradual increase in the pressure. However, in the restrictive filling defects, like we discussed, the left atrial pressure is reasonably high. Mitral valve opens there. The left ventricle pressure drops dramatically. And you have the blood flowing into the left ventricle. With a little amount of blood flow, because the stiff ventricle, the pressure rises pretty rapidly. And you have the pressure plateauing off at the end of early filling. And there's not much room for any more filling to happen. And so this is classically described as a dip and a plateau pressure waveform of the left ventricle. So this is how it would look like. This is our Doppler trace. This is the velocity. You have a very high velocity like we described at the early filling phase, and then it rapidly dies out. And as the ventricle is already quite full and the pressure is plateaued, you don't have much flow happening at the atrial systole. So just refreshing assessment of diastolic dysfunction in patients, you need to be familiar with the ASC, I think it was 2018 update on diastolic dysfunction. There's a document which is freely available online. Make sure you go through it. These are just the algorithms from that. To assess left ventricular diastolic dysfunction, what you're looking at is these 4 parameters in patients with normal left ventricular ejection fraction. If 50% are positive, it's more than 50% are positive, there's definite diastolic dysfunction. If less than 50% are positive, then it's a normal diastolic function. And if it's only 50% of these are positive, the diastolic function is indeterminate. And then there's another second algorithm, which is basically for patients with depressed left ventricular ejection fraction or patients with myocardial disease and normal left ventricular ejection fraction. So any hypertrophy or restrictive will come into this category. So here you're looking at the mitral inflow, E to A ratios. If the E to A ratio is more than 2, then you have clear grade 3 diastolic dysfunction that like we described. If it's less than 0.8, then you look at the E velocity. If it's less than 50 centimeters, then you have grade 1 diastolic dysfunction with normal left atrial pressure. And the second limb of the algorithm is if the E to A ratio is less than 0.8, plus your E velocity is more than 50, or your E to A ratio is 0.8, more than 0.8, and less than 2. Then you look at these 3 variables, and if you have 2 or 3 negative or 3 negative, then you have grade 1 diastolic dysfunction. If you have only 2 criteria is available, if there's 2 negative, you have grade 1, 1 positive, 1 negative, you cannot determine. If there are 2 positive, raised LAP with grade 2 diastolic dysfunction. If 2 out of 3 are positive or 3 out of 3 positive, you have grade 2 diastolic dysfunction and E by A ratio of more than 2. So this algorithm you need to know very well. This is a very frequently visited question by the DDU examiners, and you need to know this. Also important to know is that these are all validated in outpatient clinics. So these are not in the critical care setting. But in terms of simplifying diastolic dysfunction in critical care, I think this is quite a helpful algorithm to use. All right, so we'll go into restrictive cardiomyopathies and classification. You have myocardial, which could be non-infiltrative, idiopathic familial scleroderma and diabetes, infiltrative, which could be amyloidosis, sarcoidosis, primary hyperoxaluria, There are storage diseases, Gaucher's, hemochromatosis, Fabry's, and glycogen storage disease. Important to know that restrictive cardiomyopathies are the rarest among the group of all other cardiomyopathies. Okay, and with that, all the others like glycogen storage disease, Fabry's, Gaucher's, pretty rare. So I wouldn't expect these to be thrown at you in the DDE exam. At the most could be amyloidosis or sarcoidosis. So we'll go through the more common ones. Then with the restrictive cardiomyopathies, you can have the endomyocardial diseases. That's endomyocardial fibrosis, hypereosinophilic syndromes, carcinoid heart syndrome, radiation, toxic effects of anthracyclines. Another helpful classification of restrictive cardiomyopathy is based on echomorphology is whether you see increased LV mass and thickness, classically seen with amyloid and Fabry, and or LV dilatation and infarct pattern. So this is classically seen with sarcoidosis and hemochromatosis. However, the hallmark of all restrictive cardiomyopathies is, like we discussed, the dip and plateau pattern, so Dastard dysfunction, and biatrial dilatation with normal size ventricles, as the chamber size is usually normal. We'll go through amyloidosis. In majority of the patients, it's secondary to a systemic disorder. Okay? So you'll have other features of systemic amyloidosis, like involvement of the tongue. You'll have this is raccoon eyes. You'll have involvement of bowel, kidneys. So it will be a part of a secondary systemic disorder. You'll have normal RV and LV chamber size, biatrial enlargement, increased ventricular filling pressures. Often the only defect that you find there is a Dastard dysfunction with preserved systolic function. So systolic function will be, these will be normal or look like normally contracting hearts, but with significant Dastard dysfunction. A slither of pericardial effusion, very often seen in these patients. And when you go back and have a look at the ECG, these patients will have low voltage ECGs. So what's going on with these patients is there is extracellular deposition of this misfolded proteins. So abnormal proteins are finding their way into the meshwork of the myocardium, depositing into the extracellular matrix, and thereby interfering with the myocyte function. So you have myocyte suppression, direct cellular toxicity, apoptosis, and this all renders the myocardium very stiff. There are more than 30 different types of amyloidogenic proteins, but the most important two common ones are the AL, or the light chain proteins, and the TTR, or the transthyretin amyloid. So two different disease entities. The transthyretin cardiac amyloidosis is basically, so transthyretin is a normal protein. Okay, for some reason it mutates, and this is mostly a disease of elderly men. So it mutates, there's an abnormal protein, there's abnormal folding, and it's an insoluble protein. It just deposits in various structures. So you find this commonly in elderly men who sometimes present with for interventions for aortic stenosis, and you'll still find thick myocardium, and when you investigate them further, they'll found to have cardiac amyloidosis. Unfortunately, there's not much to be done for these patients. So the transthyretin is secreted from the liver, so there's the liver variant, mutated, goes into the myocardium and causes a cardiac amyloid. The other variant, which is the light chain variant, which is predominantly from the bone marrow. So this could be seen in young patients. And this is because of abnormal protein produced from the bone marrow, so plasma cells. They produce the light chains, so patients with multiple myeloma will have this sort of amyloidosis. Again, will be a part of the multisystemic disorder. You'll have amyloid deposition in other tissues and also the heart. Okay, so good news for these patients is that this can be treated. You treat the underlying condition, treat the underlying plasma cell disorder, and the amyloid will slowly disappear from the myocardium. So we'll go back to our patient, like we rightly described, Emma. I think the big features here to note is a very big, thick myocardium. So thick biventricular. You see the right ventricle is hypertrophied, left ventricle is hypertrophied. The seemingly reasonably well contracting ventricles. Okay, you have a big left atrium. Often these patients have pleural effusions because they are in congestive heart failure. And it's described, the speckled appearance of the myocardium was classically described. It's a more old description when more fundamental frequencies were used. These days we use harmonic imaging, and that makes the myocardium look much more softer, and the speckled appearance is sort of mellowed down. But if you use fundamental frequency imaging in these patients, you will definitely see the myocardium looking much more brighter and speckled. Our director of cardiology, echocardiology, Professor Greg Scully always says, thick ventricles, large atria with a slither of pericardial effusion, normally contracting ventricles is amyloid unless proven otherwise. So, I think this pericardial effusion, a small slither of pericardial effusion in these patients sort of is crucial making this diagnosis. So we've gone through the E and A velocities, the mitral inflow patterns. So these patients can initially have an abnormal relaxation pattern. So that is, you'll have a small E velocity and a higher A velocity. So you can have an abnormal relaxation pattern. And as the disease progresses, you start getting restrictive patterns. Okay, you'll have reduced E prime and an elevated E to E prime. Okay, so classical of Dastard dysfunction. Now, who knows what this is? Anyone does strain? Emma, do you guys do strain often?
Yeah, we do strain. That's I mean, I'm certainly a beginner, but that looks like the classics of cherry on top that they talk about.
That's right. Yeah. Yeah. So what we're looking at here, well, I'll talk to you a little bit about strain, just the basics. What's strain? Strain is basically so spectral tracking. So what the machine does is it looks at speckles in the myocardium and it tracks it over time. Okay, through the cardiac cycle. So you got to tell the machine when the aortic valve closes, and then based on that, it will track the speckles. So if you look at this diagram, it's LV, the contraction of the LV will be from the base to the apex. And so this segment will be shortening. So you can imagine if the machine is tracking the speckles are coming closer to each other during systole. Okay, so they come closer to each other, and then in diastole they go away from each other. So what you're seeing there is, if you the strain is calculated by what is the distance or the deformation in that distance between the speckles over a period of time from the baseline. So if the baseline was larger and it has now reduced in size during systole, so that's a negative strain. Yes, so the length of the distance between the two speckles has decreased over time in systole. Okay, so that's negative strain. So the normal global longitudinal strain, that is, it looks at, you can look at all the segments in the left ventricle. And what we're looking at, this one is the 17 segment model. And it's tracking along all those 17 segments. What is it doing with the strain? Okay, the normal global longitudinal strain, that is the peak strain at aortic, just before aortic valve closure, is normal is -20. Anything less than that, less negative than that, is abnormal, which means the distance between the speckles is not reducing as much as it should. Okay. So what we're seeing here is the strain is reduced in the basal segments and it's preserved in the apical segments. Okay, so this is a very classical appearance of the strain pattern. So this is called a bullseye representation of the global longitudinal strain. And you classically see this cherry on top. So this is the red, the color coding of the strain representation on this is blue is positive. That means the myocardial segments are actually elongating in systole when they should be shortening in systole, which means if there is a part of the myocardium which is dyskinetic or is being pushed away or is elongating or aneurysmal, then you will get a blue colored on the bullseye. Okay, following? So what we are seeing here is a negative strain in the apex, which is preserved, which is around -90, -20, whereas in the basal segments, it is less negative. So this is a very classical appearance of a strain on the bullseye representation of the strain. And this is because, for some reason, the apex of the left ventricle is relatively spared from the deposition of amyloid. So there is less amyloid in these patients in the apex of the left ventricle. And that's why you get this strain pattern. Now, if we go back to so this four-chamber view, in hindsight, if you look at the contraction of all the segments on the left ventricle, you can have that appreciation that the apical segments are contracting slightly better than the basal segments. Okay, so that's another important finding in these patients, the amyloidosis. So you look at the apex is contracting better than the basal segments, and that goes with amyloidosis.
Can I say something onto that previous slide? The strain one, the next one.
Oh yeah, this one.
This
yeah.
one. Let the graph. The red line and the blue line below the baseline. The GLS is the global longitudinal strain, and the GCS is the global circumferential strain. Is that right? So right. In constrictive pericarditis, the global circumferential strain is going to be less negative than the longitudinal strain, and in the restrictive cardiomyopathy is the other way around. Is that fair to say, or is it the?
So I think the more important number here would be you're looking at the global longitudinal strain.
Yeah.
And even if you're looking in constrictive pericarditis, there will be areas, especially along the lateral wall, where the strain is less negative or going towards positive, because that part of the myocardium is tethered to the pericardium. So that's constrictive pericarditis. You have the pericardium, which is holding back that part. So this part of the myocardium, and you will have reduced strain in these areas. Okay.
It's just that I found that graph interesting. I've never seen this kind of graph, I think, but I was reading it somewhere because the outer fibers of the myocardium are the circumferential ones, and the inner ones are the longitudinal ones. And that's why in the constrictive pericarditis, the global circumferential strain is less negative than the longitudinal one, while it's the other way around in the restrictive cardiomyopathy. But that's okay.
Well, I don't know much about global circumferential strain because I don't think it's a very commonly used parameter. So
yeah, because I've certainly not
used it a lot. Yeah. So yeah, I might have to read up on that a little bit. So just because we're speaking about strains, I think I found this very interesting. Different types of presentations on different sort of pattern recognition on the bullseye. What do you call? GLS this is a classical, this is normal. So you have all the strains in the red, quite negative numbers. In here you have the apex, which is spared. So again, this would be amyloid. This one, you have the inferior wall, which is affected. And this could be seen in anyone to take that?
Like an inferior MI or something.
Yeah,
like
right. So inferior MI could do this. What about this one? So you have the basal septum and the anterior segment all involved. What could that be?
Could be LAD infarct.
LAD.
Yeah, it could be an LAD infarct, or it could be a septal variant of hypertrophic cardiomyopathy. This apex, yeah, the apex is involved, but the bases are all preserved.
It's apical Holcomb.
Yeah, so it could be a Takotsubo, or it could be something like a apical variant of Holcomb. And here, this one is a very typical one where you have very patchy appearances, very non-specific.
Sarcoid.
Yes, sarcoid could do this. Also, you could see this in patients with aortic stenosis. Okay, so if you're looking at hypertrophy, hypertrophied ventricle, and you're seeing these different patterns, and then you could possibly, sort of make a diagnosis. We'll move on to the next case. This is an 84-year-old gentleman who was admitted with increasing shortness of breath. Again, worsening dyspnea for the last 1 week. Recent admission for decompensated heart failure. And he also has history of orthopnea, paroxysmal nocturnal dyspnea. He also has got history of acute kidney, so chronic kidney failure, and now he's coming with acute and chronic kidney failure. So again, similar findings: very thick ventricle, speckled myocardium, a slither of pericardial effusion. If you can appreciate, the valves are slightly more thickened. You have a very large atria, so biventricular dilatation. You can see nicely the right ventricle is also hypertrophied. So this is all going again with cardiac amyloid. Okay, so elderly gentlemen, this typical finding on the echoes, you investigate them further for amyloid. So same findings: restrictive pattern on the mitral inflow velocities. The E prime is severely reduced. The E to E prime of 43, so signifying elevated left atrial pressures. And you have the typical bullseye cherry on top pattern on the global longitudinal stain. So two different variants. This guy, elderly, not known to have multiple myeloma or any other hematological conditions. And this could be a transthyretin amyloid. Okay? They usually have a bad prognosis. Just found some interesting literature on some of the patients treated at Prince Charles. Regression of anatomical cardiac features on amyloid light chain. So this was, this patient was treated with stem cell transplant. And you can see how pre bone marrow transplant, the echo findings, a very typical cherry on top appearance. And over a period of time, 18 months after transplant, his global longitudinal strain started improving. 30 months post, it was pretty much back to normal. Okay, so it's showing us that over a period of time, if you treat the primary condition, the cardiac amyloidosis will start improving, will start reversing. Another article which showed that echocardiography, this was again a very small study on only 4 patients, but what they compared was the echocardiographic findings and the MRI findings, whether they correlated as after stem cell transplantation as the cardiac amyloidosis improved. And the bottom line there was that transthoracic echo was pretty good at following cardiac resolution of cardiac amyloid. We'll move on to the next one, that's sarcoidosis. Yeah, the typical cardiac features of cardiac sarcoidosis, mostly, arrhythmias and cardiomyopathy. These patients can present with congestive heart failure. So if you see what happens with sarcoidosis is it's a granulomatous disease. You have infiltration into the myocardium. So as there is infiltration into the myocardium initially, there's inflammation, thickening of the myocardium, and over a period of time, the myocardium is replaced by fibrosis. Okay, so you have these granulomatous inflammatory changes happening across different parts of the myocardium. And as the disease progresses over a period of time, you will have a scar tissue forming in different parts of the myocardium. Okay, what's very typical of this is you will have this scar tissue in very non-coronary territories. So you'll have them in one scar in a small territory of the LAD, you'll have another scar in the small territory of the RCA. So it does not really fit in specific coronary territories. Okay, so that's something that you look out for. Most importantly, these patients will very often present with cardiac arrhythmias rather than echocardiographic findings. Okay, congestive heart failure, they'll have systolic failure, they will present with heart failure with preserved ejection fraction, and they can also present with right ventricular failure secondary to pulmonary disease. There's also pericardial variants where predominantly they'll present with pericarditis, and the only finding sometimes could be just a pericardial effusion. So what's the role of echocardiography? It's mostly used as a screening tool. So if you know that the patient has got a history of sarcoidosis, you want to look for any complications of cardiac sarcoid. Okay. The sensitivities have been reported different depending on what literature you look at. The sensitivities are very low, anywhere between 14 to 30%. And so relying only on echocardiography to find evidence of cardiac sarcoidosis is probably not a very good choice. However, you can use echocardiography to monitor changes over a period of time. So if you've seen some changes, you can see what happens over a period of time, just as surveillance. So what are the features of sarcoidosis, cardiac sarcoidosis? Left ventricular dilatation. Okay? So these patients, differential diagnosis of patients with sarcoidosis is usually they have like an infarct pattern. They have areas of fibrosis. Like discussed, initially there is wall thickness and followed by scarring and thinning. For some reason, sarcoid tends to have a affinity for the septum. The septum is very commonly involved. So septal thinning is one of the important features. So if you're doing the A6 exam, this is one of their pet questions again. They're looking at just the basal septum involvement, having those spot diagnosis of what is this sarcoidosis. You can have segmental or global hypokinesis. Mostly this is all in non-coronary distribution as discussed. Ventricular aneurysms, valvular regurgitations, and right ventricular dilatation and hypokinesis. So really you can have something looking like a normal heart, you can just have some focal aneurysms, or it could be a dilated cardiomyopathy. Okay, so quite a varied presentation of cardiac sarcoid on echocardiography. So this is one of our patients who had cardiac sarcoidosis, so had pulmonary sarcoidosis and then had progressed to develop cardiac sarcoidosis. Anyone wants to have a go at describing these findings in this?
Hey Ramsy, how are you?
Yeah, hi Atim.
Yeah, so this looks like a Parasternal long axis view that's showing normal systolic function of the left ventricle, normal RV size, no pericardial effusion, no major pericardial effusion, normal LA size. Both aortic and mitral valves are opening normally. There is thinning of the basal septum, of the interventricular septum compared to the rest of the walls.
Yeah, so right, so the basal septum, if you can see here, is thinned out. So is it hypokinetic, kinetic, dyskinetic?
It's normal wall motion, but it's definitely thin, and there is a potential as well that could present as a septal aneurysm, but would like to view it from different view as well.
Okay, so I think you said normal normal wall motion, but it is sorry, I missed
Do you think
what you
it's
said.
do you think it's dyskinetic? In this one that you are looking at, probably it could be dyskinetic.
Okay, so when you're describing these findings for the DDO exam, or even if you're reporting, it's either normal. So what is normal normal motion of the wall? What is the normal contraction?
So it should be contracting more than 60%.
Yeah, so it should be thickening more than 50%. Okay.
Yep.
So if the base diameter or the thickness of the ventricle wall is say 1 centimeter, at peak systole, it should be 1.5 centimeter.
Yes,
the thickness
exactly.
of the ventricle wall, right?
Yep.
So it should be thickening more than 50%. Good. So that's normal. Less than 50% is hypokinesis. Okay.
And 10% to be akinesis.
And if it is not thickening at all, that is akinesis. What is dyskinesis?
Dyskinesis is a movement in the abnormal direction. Within systole, it will be actually contracting outside.
Yeah. So in systole, it will be actually moving paradoxically. It will be moving instead of moving into the cavity, it will be moving out of the cavity. Okay. So you've got to have those nomenclatures right. And I think another important pet question for the examiners is talking about the coronary territories. Okay. Yep. So what coronary territory supplies that area?
So that should come from the left anterior descending, or in very small minority, it may come still from the left circumflex.
Yeah, right. So that's correct. And I would again describe this as it's almost looking like it's dyskinetic, isn't it? It's moving in the opposite direction, systolic. So it is a dyskinetic basal septum. Okay. And what is remarkable in this is the middle part of the septum is actually contracting quite normally. And it's the basal septum, which is almost dyskinetic. So you see that marked difference there in the basal septum, and the mid septum is all supplied by the LAD. So the basal septum is akinetic or dyskinetic. Then why is the mid septum not akinetic or dyskinetic? Right. So it's not fitting in a coronary territory. And so when you pick up these findings, then you got to be thinking about localized scarring, localized inflammation, what's going on there. All right, so 4-chamber view. If you see the apex here, again, the apex is not contracting. It is akinetic. The lateral wall is contracting well. Again, the apex seems to be almost aneurysmal. Okay, it is definitely dyskinetic. It's moving outwards in systole. So you have areas of myocardium. Again, apex could be LAD territory, but you're having a skip lesion, sort of basal septum, apex, but the mid septum is contracting well. So it doesn't fit in the LAD territory in part, isn't it?
Yeah, exactly.
Okay, so when you find these patchy appearances on the echo, some areas of focalized scarring, then you've got to be thinking about sarcoid. All right,
oh, sorry. I was just going to ask if that patient had contrast. Did they have a contrast echo after that to see the apex a bit better?
Yeah, they did have. The apex was definitely akinetic. I should have put that up. But it was definitely akinetic. It was aneurysmal, and there was no clot in the left ventricular apex. All right, we'll move on to the next case. This is a 70-year-old male, progressive increasing shortness of breath over the last 2 years, exercise tolerance of 100 meters on flat, no respiratory comorbidities. He's had investigations for this. He's had lung function test done, which is normal. He's a non-smoker. And he was admitted to ICU for hypoxic respiratory failure. And as they do for hypoxic respiratory failure, we do an echo. This is the echo that was done. Apologies, they are not very great quality images, but that's the reality of intensive care, echoes in intensive care. Who wants to go? Who wants to have a go at this?
I can attempt.
All right, good.
This is the parasternal long axis view demonstrating the normal thickening of the right ventricle, which is probably mildly dilated. Left ventricle has got normal contractility with no significant regional wall motion abnormalities. Mitral valve is opening and closing in the midline. Left atrium looks a bit bigger, a bit enlarged as compared to the aorta. The aortic valve, the annulus is, the anterior annulus is appearing a bit calcified or thickened, and the ascending aorta is normal sized. No pericardial effusion visible.
All right. You mentioned something about left atrial dilatation.
Yes.
Sorry. Okay, this is the next one. Again, just a better view of the parasternal long axis. Again, confirming the same findings that, like you said, the left ventricle. What do you think about the left ventricular cavity size?
And systolic is probably normal. Looks normal size to me.
Okay. And what do you think about the thickness of the myocardium?
About 0.5 to 1 centimeter. Looks normal thickness.
Yeah, I agree with you. I mean, it doesn't look like it's not looking like it's obviously hypertrophy. Obviously,
No.
you'll measure the walls. The left ventricle was not hypertrophied, okay?
No.
And the cavity size was almost normal.
Yes.
Okay, but you mentioned something about left atrial dilatation. So the
Yes.
left atrium looks dilated, okay?
It's a qualitative assessment.
Yeah, and when we measured the left atrium on this patient, the left atrial volume index was 50 mils per square meter. So what do you want to know more? What else do you want to know?
So I want to, because it's a sinus rhythm, I want to check the left ventricular filling pressures and the diastology of the heart.
Okay.
And also the ejection fraction and the cardiac output, which looks up here, and also any kind of, if there is any valvular dysfunction, there's no mitral valve abnormality I could see on this 2D view assessment. Yeah. But I still want to see if there's any mitral regurgitation and the severity of the mitral regurgitation to look for the reasons for enlarged left atrial volume.
Good. So that's really a good description. So you want to really talk about, so when you find an enlarged left atrium, you got to really start thinking about why is the left atrium enlarged? Because one of the criteria for talking about diastolic dysfunction is your left atrial enlargement. So is it your left ventricle filling pressures that's actually causing that? Is it your mitral valve? And then you work your way backwards, talking about the changes in the pulmonary circulation and the right ventricle. So talking about tricuspid valve regurgitation, talking about the TRV max. So that's your parasternal long axis inflow view of the right ventricle. And when we put color Doppler through it, unfortunately, we did not get much tricuspid regurgitation. Okay, so we couldn't get tricuspid regurgitation. Right. That's a short axis view at the mitral valve. Unfortunately, we didn't get very good views at the mid-papillary level.
Yeah, it's at the mitral valve level, but you can see the D-shaped septum. I mean, I don't know whether that is the right window to describe it, but there is a D-shaped septum with the right ventricular enlargement that we could see both in systole and diastole. So probably pressure overload. Yeah,
so probably there's some degree of pulmonary hypertension.
Yes.
But we couldn't pick that up with because we didn't have enough TR. All right. So you said you want to assess the diastolic dysfunction. Okay. So then we put the pulse wave Doppler across the mitral valve. So yeah, the left atrial volume index, like I said, was 50 mils per square meter. And you have your E and A velocities.
Yeah, so we are into that middle territory, whether it is a grade 1 or a grade 2 diastolic dysfunction. In this E to A ratio is 1.3, which is less than 2, obviously.
So Sid, which algorithm are you following? Are you following the algorithm? That is the first one or the second one?
No, I
so
should be.
Is that diastolic dysfunction?
Yeah, I should be looking at the first one, not the second one, because the LV systolic there's no LV systolic dysfunction I could see on the qualitative assessment.
Yeah.
So the first one I should be looking at. So I could only see one criteria in this one, which is the E to A ratio, which is 1.3. There was not much tricuspid regurgitation. Left atrial volume was enlarged, so 2 positive, 2 negative. I could not see. I need to check the E to E prime as well.
Okay, so let's have a look at the E to E prime.
So E lateral is 10 centimeter per second and E to E lateral is 8. E to E septal is 12. So E lateral is smaller than the septal, with an average around 7. Okay, so because usually the septal E prime is smaller than the lateral E prime, this points towards, and putting everything together, this patient has got a normal systolic functions, enlarged left atrium with reduced E prime lateral, and I would like to see that 2D window again to look for the septal bounce or any kind of septal enlargement, especially with the respiratory pattern, to confirm whether it is a constrictive pericarditis. Yeah, there might be a septal bounce I could see during systole, but again, I need to see it with the respiratory pattern with a reduced kind of.
Okay, Sid, tell us a little more about why you think it's a constrictive pericarditis.
Yeah, because the few things, septal bounce, I need to confirm it with the respiratory pattern. That is one thing. Yeah. But a couple of important factors. I could not establish the definitive cause of left atrial enlargement. Yeah. That is one thing. But the left atrium is significantly enlarged, which is about 40 or 50 mils per centimeter cubic. But the E prime on the lateral annulus is lower than the E prime at the septal annulus, which is a very important finding, I would think, to describe to point towards the constrictive pericarditis.
Okay, so what are the other features of constrictive pericarditis? What other findings would you get to support this? So what is that called? What you're describing, what is that called?
So annulus reversus.
Yeah, that's right. So it's called annulus reversus. Okay, so what you're seeing there is basically like we described in constrictive pericarditis. You have the lateral wall of the myocardium, which is tethered to the pericardium because the pericardium is inflamed. It was inflamed at one stage, and it's now fibrosed. It is holding back the myocardium. So you don't get normal movement of that lateral annulus. Okay, so your E prime velocities on the lateral annulus are going to be reduced. So because of that, what happens is the medial annulus is sort of sometimes compensating for that, and the E prime on the medial annulus might be higher. Okay, so the E prime septum, which was normally less than the E prime lateral, is now suddenly greater than the E prime lateral. Okay, and what's the normal cutoff value for E prime septum?
It's about 7 centimeters per second.
Yeah, it's about 7 centimeters, and lateral is usually around 10 centimeters, more than 10 centimeters. Okay, but you can see here that the E prime septum is actually much higher than what it should normally be. It's around 12. Okay, so you have the septal E prime, which is much higher, and you see the lateral E prime, which is 10, which is sort of still in the normal range, of the lateral E prime, but the septal E prime is higher. Okay. There's also another important feature that you see is called the paradoxes, annulus paradoxes, and that is basically your E to E prime ratio is actually lower, despite having evidence that your left atrial pressures might be elevated. Okay, and that's again purely because your E prime septum is higher than what it should be. Okay, so that's a good pickup. Well done. You also get this respiratory variation. Okay, so you get, depending on what textbook you read, the cutoff for the mitral. So you were describing the septal bounce, and that's basically the interventricular dependence through respiration. Okay, so this is again interventricular dependence through respiration. So you will get this variation in the mitral and the tricuspid flows, depending on what textbook you read. Bonita Anderson gives the cutoff for the mitral flows at 40%. Okay, for constrictive pericarditis, and for tamponade it's 30% mitral and 60% tricuspid. So you get this respiratory flow variation. Another important finding is also when you look at the hepatic venous flow, you get something called as the diastolic flow reversal. So again, normal flow through the hepatic vein, it is like the pulmonary vein. You have a predominant systolic flow, so predominant forward systolic flow. Then you have a diastolic forward flow, and then you have the atrial reversal. So you see that that's systole. So you have the systolic forward flow. So that's the flow going this way towards the heart. So systolic forward flow. And then you have the diastolic forward flow, and then you have the aortic, the A reversal. Okay. So what happens in constrictive pericarditis is the pericardium is restricting the ventricular capacity to accommodate blood. So in inspiration, when you take a deep breath in, you have more blood coming to the right ventricle, and that in a way impedes the filling of the left ventricle. Okay, so your right ventricle is now having enough volume, and in expiration the reverse happens. So in expiration you have more blood coming to the left ventricle, and it is now impeding the filling of the right ventricle. So what you get in constrictive pericarditis is in expiration your atrial flow reversal suddenly goes up. It increases. The velocity there increases. And the diastolic component of it decreases. It's not very classically seen in this particular example, but what you would normally see is this diastolic component becomes smaller and this reversal becomes bigger. You get a larger reversal and a smaller diastolic forward flow. So that if the reversal is more than 30% of the forward flow, forward diastolic flow, then it's quite sensitive for constrictive pericarditis. Okay, so the reason why I brought this case up here was you have someone, now these patients can actually have, when you do an E and A ratio, you can actually have what looks like a restrictive pattern. Okay, so you have restrictive pattern, you have features suggestive of raised filling pressures. So it can be quite difficult to differentiate if you're not looking for the E prime and the two specific signs for constrictive pericarditis, that is your respiratory variation, septal bounce, and your annulus reverses and annulus paradoxes. You can miss constrictive pericarditis. Okay, so quickly going through that, what you'll also find is pericardial thickening. You can find a restrictive filling profile on the mitral E and A velocities. There's increased respiratory variation to mitral and tricuspid inflow velocities. You have annulus reverses, annulus paradoxes, IVC plethora. That's your IVC is large and there's not much respiratory variation, and your intraventricular septal bounce. This is another pet question of DDU examiners, is how do you differentiate, what are the differentiating features between echo findings of constrictive pericarditis and restrictive cardiomyopathy. Okay, so this is commonly available in all textbooks. It's this table is taken from Bonita Anderson's textbook, so you'll find it there, and make sure you know the differences between restrictive and constrictive pericarditis. All right, so in summary, restrictive cardiomyopathy, it is the rarest form of cardiomyopathies. Diastolic dysfunction is the hallmark of these cardiomyopathies. It can have different echo findings based on the pathology and the different phases of the illness. It can be difficult to diagnose on echocardiography alone. So you want multimodality imaging or diagnostic techniques, which could include nuclear scanning, MRIs, or for amyloidosis, even biopsies, endocardial biopsies. So differentiating from other pathologies can be difficult. So the differential diagnosis for amyloid would be your hypertrophic cardiomyopathy. It could be your aortic stenosis. So just a hypertrophied heart. Whereas for the other phenotype, that is sarcoid, it could be coronary artery disease. Okay, so it could be quite difficult, challenging, and echocardiography is a useful monitoring tool. So I think from the DDU point of view, if you have a clear understanding of identifying diastolic dysfunction and knowing a little bit about restrictive cardiomyopathies, I think that should make it. Any questions?
Thank you so much, Ramsy. That was pretty awesome. It's my job to pick out a pearl to put along with the the talk, but you gave too many, so I've got a tough job picking out which one to use there. Thank you so much.
Right.
I was listening to a talk, an ASC talk by J.O. on this topic, and he, because the classical teaching for constrictive pericarditis is that is that they often don't have a right ventricular systolic pressure of less than 50. That was like the classic teaching, is that they often don't have pulmonary hypertension with constrictive pericarditis. But he was saying that that's essentially a myth. And I think it came from sort of Liz Hattle's work, I think, back in like the mid 1980s. And he was saying that, a lot of the patients that come through his Mayo Clinic with constrictive pericarditis, in fact, do have significant pulmonary hypertension as well. I thought that was interesting to remember, because the classic reading when you read about it is that they don't have, right ventricular systolic pressures that are that high.
Yeah, physiologically it makes sense, isn't it? I mean, if you're having raised left atrial filling pressures over a period of time, depending on how long the pathology has been there, you would think there would be back pressure. But I agree. I mean, that's the traditional teaching that patients with constrictive pericarditis usually don't have much right ventricular systolic pressures. That's right.
Thank you. I'll have to now decide which pearl to add to your video. Thanks so much.
Excellent. No worries. Thank you very much.
Thank you,
Ramsy. That was excellent.
Thank you very much, Ram.
No worries. Thank you.
If you learnt something, hit like and subscribe to our channel for more videos uploaded weekly.
For bite-sized versions, follow us on Twitter @EchoNepean and check out the tutorials.
Or head over to our websites for the latest hands-on courses. Links in the channel banner.
And thanks for watching.